Welcome to Deep Dive Ortho, the show where we really get under the skin of topics critical to clinical practice. We aim to sift through the complexities and pull out the insights that matter most for you, our dedicated medical professional listeners. Today, we're tackling a symptom that seems simple, but actually presents a huge diagnostic challenge. Arm weakness. The differential is broad, often incredibly complex. And guiding us through this intricate landscape is a leading expert known for synthesizing complex medical information into clear, effective clinical guidance. Welcome.
Thank you. It's a real pleasure to be here. And arm weakness, yes, it's certainly a widespread concern we see day in, day out in clinical practice. It affects a significant number of adults, especially perhaps those over 60. And the way it presents is just so varied. It can be anything from a minor transient issue like an overuse strain that gets better quickly, right through to a really serious, sometimes even life-threatening condition needing immediate action. But the crucial starting point always is this. We absolutely must distinguish true muscle weakness from, say, subjective feelings of fatigue or limitations that are purely down to pain.
That's key, isn't it? If someone's not moving their arm because it hurts intensely.
Exactly. Their actual muscle strength might be perfectly normal, but it can look very much like weakness. Getting that initial differentiation right is paramount. It really does set the whole diagnostic direction.
That's a vital clarification right at the start. So when we talk about arm weakness in that clinical sense, how do we formally define it? And what are those key distinctions we need to make right away to avoid going down the wrong path?
Well, fundamentally, arm weakness, or paresis, as we often term it in clinical notes, is a quantifiable and objective loss of muscle strength. It results in a demonstrable difficulty moving or using the arm effectively. Now, if movement is entirely absent, then we'd classify that as paralysis. But that first hurdle, as I said, is discerning this true loss of strength from general fatigue or from motor impairment caused purely by pain. Think about a patient, let's call him Mr. Harrison. If he comes in complaining his arm feels weak, but the root cause is severe shoulder pain, say from tendinitis.
He'll naturally limit his movement to avoid the pain.
Precisely, making it appear weak, even if the nerves and muscle fibers themselves are technically fine. Our job is to probe beyond that initial presentation. And the presentation itself varies hugely too. It might affect just one arm or both sides symmetrically or asymmetrically. The onset is also critical. It can be sudden, seemingly random, or can creep up gradually over weeks, months, even years.
And the duration?
Equally variable. It could be temporary, resolving with the right treatment, or it might become a chronic issue lasting months or years, particularly if the underlying cause isn't properly addressed. So a key insight here is that understanding the time course of the weakness is often just as important as figuring out its distribution.
Okay. So once we're confident we're dealing with genuine objective weakness, what are the associated symptoms that should immediately ring alarm bells for a clinician? What are those red flags telling us this might be more than just a simple strain?
Yes, these accompanying symptoms are absolutely invaluable diagnostic clues, especially when you look at their combination and how they're progressing over time. When patients describe sensory changes, we're listening very carefully for specifics. Tingling, often the classic pins and needles, or outright numbness, a loss of sensation. They might report burning feelings, shooting pains, sharp, stabbing, or prickling sensations. Sometimes they even describe these zinging or electrical shock feelings traveling down the arm.
All suggesting nerve involvement?
Exactly. Direct nerve irritation or damage. Then on the motor side, beyond the weakness itself, we need to look closely for difficulty lifting or gripping things. Maybe unintentionally dropping objects. Muscle cramps or spasms are significant. And particularly, we look for visible muscle wasting or shrinkage that we call atrophy. Involuntary muscle twitching, fasciculations, especially if they're persistent, are also direct indicators of some underlying neuromuscular issue. These are the sort of local red flags for the limb itself.
Right. And beyond the arm itself, what systemic or neurological signs elevate the concern?
Well, there's a range of systemic or broader neurological signs that demand immediate attention. For instance, finding a new lump on the arm along with the weakness definitely warrants thorough investigation. Shortness of breath is critical. It could mean respiratory muscles are involved, which is obviously a life-threatening situation. Any new confusion or altered consciousness, difficulty chewing, swallowing, or speaking, especially slurred speech, dysarthria, these are highly concerning signs pointing towards central neurological compromise.
Like a potential stroke or brain lesion?
Precisely. Complete paralysis or immobility in any body part, not just the arm, is an obvious emergency. Other systemic signs like unexplained fever, itching, profound lethargy or malaise, or localized redness, warmth, or swelling in the arm itself also need careful thought. They might point towards infection or inflammatory processes. And of course, a severe headache, especially if it's described as the worst headache of your life, or any sudden changes in eyesight or vision loss. These are profound red flags needing urgent neurological assessment.
So the clinical picture is key.
Absolutely. The clinical nugget here is never view these symptoms in isolation. Understand how they cluster together and how they evolve over time. That combined picture is your most powerful diagnostic tool.
Okay, that makes perfect sense. So arm weakness clearly stems from a huge range of potential causes crossing multiple body systems. To bring some clarity for our clinical colleagues listening, where do we even begin to categorize these? It sounds like we need a really systematic map.
Precisely. A systematic approach is essential to navigate this effectively. I find it helpful to group the causes broadly. First, neurological, which we can split into central nervous system and peripheral nervous system. Then, musculoskeletal causes. After that, systemic or endocrine factors. And finally, iatrogenic, meaning medication-related or environmental causes. This framework just helps organize our thinking when faced with that broad differential.
Right, let's start with the neurological then. Central nervous system first.
Yes. And within the CNS, stroke is undeniably the most common cause of unilateral arm weakness. When blood flow to specific brain areas is compromised, it directly impacts motor control pathways. So, for example, a lesion in the left hemisphere typically causes weakness in the right arm and vice versa.
Because the nerve fibers cross over.
Exactly. That's the concept of decussation happening in the brainstem. The frontal lobe, in particular, houses the motor cortex controlling voluntary muscles. So an infarct or bleed there can lead to weakness, often seen as that classic arm drift when a patient tries to hold both arms out. And that's why the FAST acronym face drooping, arm weakness, speech difficulty, time to call emergency services remains so critically important for early stroke recognition and intervention.
Still the cornerstone of public awareness campaigns.
Absolutely. Now, an interesting point on stroke prevalence data. More recent studies suggest upper limb weakness early after stroke occurs in perhaps 40 to 57% of patients. This is actually lower than older figures, maybe from 20 years ago, which often quoted 70 to 80%.
Why the difference?
Well, it's likely not a change in the stroke itself, but reflects improvements in how we measure weakness and maybe faster initial treatment. The specific tool used matters, like the SAFE score versus the NIHSS ARM score. Also, when post-stroke, the weakness is measured, and the characteristics of the patient group studied single center versus multi-site, for example.
So the way we measure and study it evolves.
Exactly. The key insight is that even the statistics we rely on are dynamic. They reflect not just the disease, but our evolving diagnostic tools and research methods too.
That's a crucial point about interpreting research, isn't it? Now, just to clarify further for our listeners, the terms hemiparesis and hemiplegia often come up with stroke. What's the distinction, and why does it matter clinically?
Great question. And yes, it's a vital distinction for prognosis and planning. Hemiparesis refers to one-sided weakness, so partial loss of strength, impaired movement on one side. Hemiplegia, on the other hand, means complete one-sided paralysis, a total inability to move that side.
So plegia is much more severe.
Correct. The distinction is paramount for predicting recovery potential and for tailoring the intensity and type of rehabilitation needed. A patient with hemiplegia faces a significantly longer and more arduous recovery journey, although both conditions require intensive dedicated support.
Okay. And beyond stroke, what other CNS lesions can cause arm weakness?
Well, quite a few serious conditions. Aneurysms rupturing or hemorrhages within the brain tissue itself, traumatic brain injuries, TBIs, and concussions, especially if motor pathways are affected. Brain tumors, whether primary or metastatic, can compress or invade motor areas, and bleeding between the brain and its protective layers like subdural or epidural hematomas can also cause focal weakness due to pressure effects. Then there are neurodegenerative and autoimmune conditions. Multiple sclerosis, for example, involves demyelination, which disrupts nerve signals, leading to progressive weakness. Progressive multifocal leukoencephalopathy, PML, is another devastating condition.
And infections.
Yes, infections directly affecting the brain or meninges, like encephalitis or meningitis, can cause inflammation and neurological deficits, including arm weakness. Ramsay-Hunt syndrome, caused by varicella-zoster virus reactivation, is another example affecting cranial nerves, but sometimes associated limb weakness. Even seizures or epilepsy can lead to temporary focal weakness afterwards, known as postictal or Todd's paralysis. It usually resolves within hours, but can be alarming initially.
So the key takeaway is Any new focal neurological deficit needs urgent investigation.
Absolutely, including imaging, usually MRI, to rule out a structural brain lesion. That's non-negotiable.
It's remarkable how many central issues can present this way. You mentioned rehabilitation earlier. Are we seeing technological advances helping with chronic brain injury, specifically for diagnosing and treating this kind of persistent arm weakness?
Yes, absolutely. This is a really exciting and rapidly developing area. For managing the long-term effects of chronic brain injury, we are seeing significant progress with robotic and mechatronic devices. Tools like the AirArm Guide, for instance, are being developed. These are clever because they serve a dual purpose.
Diagnosis and treatment.
Exactly. They can help diagnose impairments like abnormal muscle tone, incoordination, and weakness in a much more quantifiable, objective way than purely subjective clinical assessment allows. But they also function as therapeutic tools. They allow therapists to implement and evaluate things like active assist therapy, where the device helps the patient move their arm through desired patterns. Initial results from studies using these devices are really promising. They're showing measurable, quantifiable benefits for patients with chronic hemiparetic arms, offering a new dimension to neurorehabilitation.
So a move towards more data-driven therapy.
Precisely. It signifies a shift towards more objective, targeted, and potentially more effective rehabilitation strategies for persistent weakness after brain injury.
That's genuinely exciting, offering new hope. Okay, so let's move down from the brain and central nervous system. What about causes originating in the peripheral nervous system and the spinal cord? This seems like another huge area where arm weakness commonly arises.
It is indeed, and these peripheral causes are incredibly common in everyday clinical practice, perhaps even more so than the central ones for many presentations. Nerve compression syndromes are particularly prevalent. Carpal tunnel syndrome is the classic example, the most common one we see.
Compression of the median nerve at the wrist.
That's right. It typically causes numbness and pain, often worse at night, which can radiate up the forearm, sometimes into the elbow, and occasionally even felt in the shoulder and neck. It's very often linked to occupational or recreational activities involving high force, repetitive finger and wrist movements, or prolonged use of vibrating tools.
And more common in women.
Yes, interestingly, women are about 3 times more likely to develop it. Then there's cubital tunnel syndrome, the second most common compression neuropathy. This involves the ulnar nerve being compressed at the inner aspect of the elbow. This can result from chronic pressure, like people who habitually lean on their elbows or activities involving repetitive pulling, lifting, or reaching.
Causing numbness in the little and ring fingers.
Typically, yes. And radial tunnel syndrome involves the radial nerve being pinched or compressed near the elbow, impacting forearm rotation, elbow extension, and wrist and finger movement. The clinical takeaway for all these compression syndromes is always dig into the patient's history regarding occupation, hobbies, and repetitive activities.
Makes sense. What about more direct injuries to nerves?
Well, brachial plexus injuries are another significant category. The brachial plexus is that complex network of nerves running from the neck into the arm, controlling essentially all muscle and sensory functions. Trauma, like a severe fall, a motorcycle accident, or even sometimes during birth, or compression of this plexus, can lead to a huge spectrum of problems, from just limiting movement at a single joint right up to complete paralysis and sensory loss in the entire arm.
Devastating injuries.
They can be.
Yeah.
And direct nerve injuries themselves, like deep cuts or crush injuries, can also be catastrophic. They cause profound functional loss, weakness, and often really debilitating chronic pain due to the formation of painful neuromas.
Those sensitive nerve endings.
Exactly. The good news, though, is that even relatively minor surgical procedures can often effectively repair the nerve injury or treat the neuroma, leading to substantial improvements in both pain and quality of life for these patients.
That's encouraging. And what about problems originating in the spine itself?
Crucial area. Issues directly within the spinal column impacting the spinal nerves or the spinal cord itself are very important causes of arm weakness. This includes common things like pinched nerves in the neck, often from degenerative changes like disc herniation. A herniated disc is where the cushioning material between the vertebrae bulges out, pressing on a nerve root. This often happens due to natural age-related wear and tear. You could also get crowding of the nerve roots in the neck, which we call cervical radiculopathy. Inflammation in the spine can cause bone spurs, osteophytes, to form, which can then physically press against nerves. More seriously, spinal cord compression itself, perhaps due to significant spinal canal narrowing, stenosis, or a large central disc herniation, can cause weakness in both arms, potentially legs too, along with other neurological signs. And finally, we have peripheral neuropathy. This is widespread nerve damage, often linked to systemic diseases like diabetes. It doesn't just cause sensory symptoms, it significantly increases the risk of nerve compression syndromes and can directly cause motor nerve injury and weakness in the arms as well.
So a diabetic patient presenting with arm weakness needs careful assessment for both neuropathy and superimposed compression.
Absolutely. Differentiating between a nerve root problem, radiculopathy, a plexus injury, and a peripheral nerve lesion requires meticulous clinical examination, often backed up by electrodiagnostic studies like EMG and nerve conduction studies.
It's clear the nervous system, both central and peripheral, is often implicated. But what about problems arising directly within the muscles themselves, myopathies, or issues related to a person's overall systemic health? Where do they fit into this diagnostic puzzle?
You're absolutely right. The muscular system and broader systemic health are equally critical pieces. We can't have a complete picture without considering them. Let's talk about muscular causes, or myopathies, first. These are conditions where muscle weakness is the primary predominant feature. For example, dermatomyositis. This often presents with acute or subacute proximal weakness, so difficulty with things like getting up from a chair or lifting arms overhead, and it comes with very distinctive skin signs.
Rashes.
Yes, that characteristic violaceous rash on the knuckles, Gautran papules, or over the eyelids, the heliotrope rash. It can also appear in the upper chest and neck, the V sign, or across the back and shoulders, the Scholl sign. In contrast, polymyositis presents with similar acute or subacute proximal weakness, but crucially, without those telltale skin changes. Then there's necrotizing myositis. This is typically characterized by profound, often quite acute, proximal weakness. It can sometimes be linked to a preceding viral illness, an underlying malignancy, or, importantly, associated with statin use.
A key medication side effect to consider.
Definitely. An inclusion body of myositis tends to affect older adults, usually has a much more gradual onset, and often initially presents with distal weakness, especially in the forearm and hand muscles, perhaps causing difficulty with fine motor tasks before progressing to a more asymmetric pattern involving proximal muscles too. These primary muscle disorders often require specific blood tests, like CK levels, and frequently a muscle biopsy for a definitive diagnosis.
Okay, what about more common musculoskeletal issues, strains, overuse?
Yes, absolutely common culprits, particularly in orthopedic and primary care settings. Muscle strains or overuse injuries, often falling under the umbrella of repetitive stress injuries or RSIs. These result from prolonged repetitive use of the same arm movements, gradually damaging nerves, muscles, and tendons. They can also be triggered by sudden, unaccustomed, strenuous exercise.
Like the weekend warrior scenario.
Exactly. And if these are ignored, they can unfortunately lead to persistent pain and weakness, sometimes even permanent damage. So, if our hypothetical patient, Mr. Harrison, the architect, suddenly took up intense DIY over a weekend, an RSI would be high on the differential list for his arm weakness. A very specific muscular injury worth mentioning is an acute biceps brachii tendon rupture.
Usually the long head.
Most commonly, yes, the proximal long head tendon. It's often associated with some degree of trauma, but frequently occurs in patients who already have underlying overuse issues and tendinopathies in the shoulder. The classic presentation is sudden pain, maybe an audible pop, followed by a visible deformity of the biceps muscle, that characteristic Popeye sign, or distal bunching of the muscle belly, and tenderness over the front of the shoulder. Now, while many of these are managed conservatively with good outcomes, surgical repair might be considered, especially for younger, highly active patients, to minimize any potential long-term loss of elbow flexion and particularly forearm supination strength. This is crucial for people needing strong rotational force in their work or sports.
That's a very clear picture of the muscular issues. Now, shifting focus slightly, what about the systemic and endocrine causes? These often feel like the great masqueraders in medicine, don't they? Their symptoms can be so diverse.
They absolutely can be. And you're right, they often require a high index of suspicion because the arm weakness might just be one piece of a much larger systemic puzzle. Thyroid disorders, for instance, both hyperthyroidism and hypothyroidism can cause muscle weakness, typically proximal. Hyperthyroidism can also cause bulbar weakness affecting speech and swallowing. And interestingly, thyroid dysfunction specifically increases the risk of developing carpal tunnel syndrome.
A double hit, potentially.
Indeed. Adrenal insufficiency, Addison's disease, can cause generalized weakness, fatigue, and electrolyte disturbances. Conversely, endogenous glucocorticoid excess, Cushing's syndrome, characteristically affects proximal and postural muscles, leading to difficulty standing up or climbing stairs, often alongside those classic features like central obesity, a buffalo hump, and purple striae. Diabetes mellitus is a major player systemically. Diabetes-related nerve damage, Peripheral neuropathy is common and significantly increases the risk of nerve compression syndromes, as well as directly causing motor weakness itself. Obesity, too, simply due to the increased mechanical load, can put additional strain on nerves and joints, contributing to compression neuropathies and activity-related weakness. And crucially, electrolyte imbalances. These are frequently overlooked but can have a profound impact on muscle function, leading to either acute or chronic weakness. Disturbances in calcium, phosphate, and particularly potassium are common culprits.
Hypokalemia.
Yes, low potassium or hypokalemia. It can be caused by many things, commonly diuretics, but also certain genetic kidney disorders like Gittleman syndrome, renal tubular acidosis, conditions like primary hyperaldosteronism, thyrotoxicosis, or even some infections, dengue fever being one example. Sodium imbalances can also play a role.
So basic blood tests looking at electrolytes are essential.
Absolutely. A basic metabolic channel should be part of the initial workup in almost any case of unexplained weakness. Moving on, genetic causes. While many muscular dystrophies present in childhood, some forms, like Becker muscular dystrophy or myotonic dystrophy type 1 or 2, can certainly manifest or worsen significantly in adulthood. Certain metabolic disorders affecting lipid or glycogen storage or mitochondrial diseases are also important rare causes to consider, especially if the picture doesn't fit elsewhere.
Right, and what about medications or toxins, the iatrogenic and environmental factors?
A huge area, and one that demands a meticulous medication review in every single patient presenting with arm weakness. Never underestimate the potential for drugs to cause this. Chemotherapy drugs are known culprits. Statins, widely used for cholesterol, are well known to potentially cause myopathy, muscle aches, and in rare cases, severe rhabdomyolysis. Fluoroquinolone antibiotics have been linked to tendinopathies and even tendon ruptures, which would obviously cause weakness. And systemic glucocorticoids, like long-term prednisolone, can cause a specific type of non-inflammatory myopathy, primarily affecting proximal and postural muscles.
So that drug history is vital.
Absolutely critical, including over-the-counter medications and supplements, too. Then there are toxic exposures. Heavy metals like arsenic, lead, thallium, and mercury can all cause motor neuropathies. Organophosphate poisoning, often from pesticides, severely affects the neuromuscular junction, leading to profound weakness. Alcohol is both neurotoxic and myotoxic. Chronic heavy use can cause alcoholic myopathy, and even acute binge drinking can sometimes precipitate acute muscle weakness or rhabdomyolysis. And certain recreational drugs, things like cocaine, amphetamines, opioids, or even solvent abuse like glue sniffing, have all been implicated in causing muscle weakness through various mechanisms.
Goodness, the list is extensive. What about infections beyond the CNS?
Yes, beyond those directly hitting the brain or spinal cord, a surprisingly broad range of systemic infections can manifest with muscle weakness, often challenging our initial diagnostic assumptions. This includes viruses like West Nile virus, HIV, dengue fever, cytomegalovirus, hepatitis C, herpes simplex virus 1, bacterial infections like Lyme disease or diphtheria, parasitic infections such as neurocysticercosis, trichinosis, Chagas disease, even rabies and botulism, though rarer, present with characteristic patterns of weakness.
So infection needs to be considered, especially with fever or relevant travel history.
Definitely. Infections can be true masqueraders. A high index of suspicion is needed. Lastly, we have age-related conditions, particularly what we call catabolic syndromes, which are highly prevalent in older populations. Sarcopenia and frailty are common multifactorial syndromes, especially in adults over 60. They present as generalized weakness due to the age-related loss of muscle mass and strength, often accompanied by slow gait speed, reduced grip strength, unintentional weight loss, fatigue, and low physical activity.
Making older adults more vulnerable.
Exactly. These syndromes significantly increase the risk of falls, disability, hospitalization, and institutionalization. And they can worsen dramatically even after short periods of bed rest. Closely related is deconditioning or disuse atrophy. Significant muscle wasting can happen remarkably quickly, even after just several days of prolonged bed rest or critical illness, for instance, in an intensive care unit setting. This is hugely relevant in our increasingly aging hospital population. Finally, just a note on the cardiovascular link. While isolated arm weakness is less common as a direct heart attack symptom, arm pain or discomfort certainly can be, especially accompanied by chest pain, shortness of breath, nausea, or sweating. And significant peripheral artery disease reducing blood flow could potentially affect arm strength over time. So any cardiovascular concerns always warrant prompt evaluation.
That's an incredibly comprehensive overview of the potential causes. Given this vast differential, it really underscores why the diagnostic process must be so systematic. For our medical professional listeners facing a patient like Mr. Harrison with arm weakness, What is the key to unraveling these complex cases? How do you approach that diagnostic journey step by step?
The key, as you say, is a precise, systematic diagnostic journey, because getting the diagnosis right directly impacts how effective our treatment will be, and it allows us to give the patient crucial prognostic information. It always starts with a comprehensive history. This is absolutely fundamental. It's our first opportunity to try and differentiate that true weakness from subjective fatigue, to really define the illness's time course, and to pick up those initial vital clues about the anatomical pattern of weakness.
So what specific aspects of the history are most revealing?
We focus intently on the onset and progression. Was the onset acute, developing over hours to days? That often points towards vascular events like stroke, severe trauma, acute infections, inflammatory flare-ups like Guillain-Barré syndrome, significant metabolic disturbances, or toxin exposures like botulism. A subacute presentation evolving over days to weeks might suggest electrolyte issues, or perhaps subacute inflammatory or rheumatologic disorders, whereas gradual, progressive weakness creeping up over weeks to months often suggests chronic neurological conditions, genetic disorders, endocrine problems, or perhaps something like inclusion body myositis. It's important to clarify. Sometimes patients report sudden weakness, but when you probe, you find it's actually been a gradual decline. They've only just noticed when it crossed a functional threshold.
Ah, the sudden recognition versus sudden onset.
Precisely. We also meticulously explore temporal patterns. Does the weakness fluctuate significantly throughout the day? Does it worsen with activity and improve with rest? That pattern is classic for neuromuscular junction disorders, like myasthenia gravis or Eaton-Lambert syndrome, or conditions like periodic paralysis. Are there day-to-day fluctuations, perhaps better days and worse days? That might be seen in multiple sclerosis or some metabolic myopathies. Or is the weakness relatively constant? The distribution of weakness is another critical clue. Is it predominantly proximal, affecting the shoulder and hip girdles? Patients might describe difficulty rising from a chair, climbing stairs, lifting arms overhead like combing hair. That pattern often points towards myopathies.
Whereas difficulty opening jars suggests distal weakness.
Exactly. Difficulty opening jars, dropping small objects, maybe foot drop causing tripping that suggests distal weakness, more typical of polyneuropathies, hereditary motor neuropathies, or perhaps early inclusion body myositis. If both proximal and distal muscles seem affected simultaneously, conditions like inclusion body myositis or Guillain-Barré syndrome might be considered. And unilateral or clearly asymmetric weakness almost always points towards a neurological cause, either a central nervous system lesion or a peripheral nerve issue like inflammation or compression.
So if Mr. Harrison says he struggles to lift his kettle, proximal, but his handwriting is fine, distal, that immediately steers your thinking towards a myopathic cause rather than, say, carpal tunnel.
Precisely. That specific functional limitation, proximal difficulty with preserved distal function, is a classic pattern directing us towards muscle-centric problems rather than a distal neuropathy. Associated symptoms provide a wealth of extra information too. Double vision, diplopia, or blurry vision could be myasthenia gravis or diabetic neuropathy. Difficulty swallowing, dysphagia, or slurred speech, dysarthria, suggests inflammatory myopathy or perhaps motor neuron disease. Facial nerve paralysis, think Lyme disease, herpes zoster, or even herpes simplex virus. Fevers, joint pains, arthralgias, or rashes. Classic signs pointing towards inflammatory or infectious myopathies. Pain is important too, especially if it follows the same distribution as the weakness. That suggests nerve compression, perhaps for rhabdomyolysis or inflammatory conditions. Paresthesia, those tingling or prickling sensations, can suggest hereditary sensor motor disorders or nerve compression. Raynaud phenomenon, fingers changing color in the cold, sometimes seen with inflammatory myopathy, a history of tendon rupture, makes you think about fluoroquinolone use. And finally, a thorough review of past medical and family history is crucial. Identifying known conditions like diabetes, thyroid disease, liver or kidney disease, cancer risks, previous infections. Asking about family history can uncover genetic predispositions. And, as we discussed, a comprehensive medication and toxin review is absolutely essential to rule out iatrogenic or environmental triggers.
It's clear the history provides an immense amount of diagnostic direction. Once that detailed history is complete, the physical examination must be where you meticulously test those hypotheses and localize the problem. How do you approach that, and what are the critical elements?
Exactly. The physical examination is where we aim to objectively confirm our suspicions, grade the weakness, and localize the lesion precisely.
We always formally grade and document muscle strength, typically using the Medical Research Council, or MRC scale. That's the familiar 0 to 5 scale, where 0 is no visible contraction and 5 is full strength against maximum resistance. It's important to recognize that grading strength between 3, movement against gravity only, and 5 can be somewhat subjective. So comparing carefully with the unaffected side, if the weakness is unilateral, is vital for improving discrimination.
And describing function helps too.
Absolutely. Describing specific functional limitations, unable to abduct shoulder beyond 90 degrees, cannot rise from chair without using arms, is often more clinically useful for tracking changes over time than just relying solely on the numeric MRC score. Visual inspection is key right from the start. Look for any asymmetry in posture or muscle bulk. Look closely for atrophy, muscle wasting, particularly in the small muscles of the hands, the face, the shoulder girdle. Atrophy of laryngeal muscles might cause a hoarse voice. We also look carefully for involuntary movements like fasciculations, those brief, fine muscle twitches. They can be subtle, but seeing them, especially in the tongue, can be a sign of motor neuron disease like ALS. Also note any dystonic posturing, kyphoscoliosis, or surgical scars. Tone assessment, checking resistance to passive movement, is important. We might also tap a muscle belly gently, which can sometimes induce fasciculations and neuropathies or a sustained contraction, myotonia, and myotonic dystrophy. A full cranial nerve examination is vital in any neurological assessment. Inspecting for facial asymmetry, eyelid drooping, peristaltosis, testing extracochlear movements, checking facial muscle strength, including the masseters for chewing power. Assessing palatal movement weakness can cause a nasal voice quality. Checking tongue movement and strength weakness causes lingual dysarthria.
And testing fatigability.
Yes, testing for fatigability is crucial if you suspect a neuromuscular junction disorder. Repeated blinking, sustained upward gaze, or repeated arm abduction can bring out weakness in conditions like myasthenia gravis. We also test the strength of the sternocleidomastoid and trapezius muscles against resistance. Cranial nerve aches 11. Strength testing needs to be systematic, covering proximal and distal muscles, as well as extensors and flexors in both upper and lower limbs for comparison and pattern recognition. For large proximal muscles, functional tests are useful. Asking the patient to stand from a sitting position without using arms, squat, and rise, step up onto a low step, or testing head flexion, extension, and rotation against resistance. Coordination and gait must be assessed. Standard coordination tests include finger to nose and heel to shin maneuvers. Observing the patient walk tells you a huge amount. Look for difficulty initiating gait, ignition failure in Parkinson's, feet seeming to stick to the floor, gait apraxia, shuffling steps, festination. Note any limb asymmetry, a dragging leg or reduced arm swing, suggesting a possible hemispheric stroke lesion. Look for ataxia, indicating cerebellar problems. Instability during turns. Difficulty walking on toes or heels suggests distal weakness or possibly a corticospinal tract issue. A spastic gait often involves scissoring and toe walking. Sensation testing helps localize lesions. Finding a clear dermatomal sensory level strongly suggests a spinal cord injury at that level. Deep tendon reflexes are crucial. Hyperreflexia, brisk reflexes, maybe clonus, typically points to an upper motor neuron lesion, but can also be seen in hyperthyroidism or hypercalcemia. Hyperflexia, reduced or absent reflexes, suggests a lower motor neuron lesion, peripheral neuropathy, or hypothyroidism.
And the Babinski sign.
Yes, testing the plantar reflex for an upgoing toe, Babinski sign, is highly specific for a corticospinal tract lesion in adults. We might also check anal tone wink and cremasteric reflexes for assessing lower spinal cord integrity. An important aspect is trying to differentiate true weakness from functional weakness or potential malingering. Look for inconsistent effort or give-way weakness, where initially normal effort abruptly collapses, or failure to appropriately engage adjacent or synergistic muscles during testing. Finally, don't forget extra neurological findings. Fever suggests infection or inflammation. A Cushingoid appearance points to excess glucocorticoids. Those characteristic rashes we mentioned are vital clues for dermatomyositis. Cardiac arrhythmias can occur with certain myopathies or electrolyte issues. And particularly in older adults, specific sarcopenia and frailty screening is important, using tools like the Fried Frailty Index or RIL scale, plus objective measures like grip strength analysis with a dynamometer and gait speed analysis using the timed up and go test, comparing results against age-specific normative data.
That's an incredibly thorough clinical assessment. Bringing all those historical and examination findings together must then guide the diagnostic investigations. What's the logical flow for ordering additional tests, and what are the key nuances clinicians should bear in mind?
Precisely. The investigation should always be guided by the clinical picture. We want targeted testing, not a scattergut approach. Routine blood tests are usually the first step. A complete blood count, CBC, A comprehensive electrolyte panel, checking calcium, potassium, sodium, phosphate, magnesium, thyroid function tests, TSH-free T3, T4. Critically, we measure muscle enzymes, creatine kinase, CK, and sometimes aldolase. These are typically elevated in myopathies and muscle damage like rhabdomyolysis. A nuance here is that CK can be transiently elevated after strenuous exercise or even after an EMG, so timing and context matter. We might also check for myoglobin in the urine, myoglobinuria, if rhabdomyolysis is suspected. Depending on the clinical suspicion, autoimmune markers, infection serology, HIV, Lyme, West Nile, dengue, and glucose HbA1c for diabetes are often included. Imaging plays a pivotal role, especially for neurological or structural causes. X-rays are useful mainly for looking for fractures or significant bone abnormalities. MRI and CT scans give much more detail. MRI is usually preferred for visualizing soft tissues, nerves, the brain, looking for stroke, MS lesions, tumors, and the spinal cord, checking for compressions, stenosis, myelopathy, Cato-Equina syndrome. MRI can also identify muscle inflammation and myositis. Specialized MRI sequences or dedicated machines can sometimes directly visualize nerve damage or entrapment in the arm. CT is often quicker and better for acute bleeds or bone detail. Ultrasound is a very useful tool, particularly for musculoskeletal issues. It uses high-frequency sound waves to image structures like tendons, ligaments, joints. It's excellent for identifying nerve entrapment syndromes like carpal tunnel or detecting tendon ruptures like that biceps tendon we discussed. It's non-invasive, readily available, and provides dynamic imaging.
What about electrodiagnostics, EMG, and nerve conduction studies?
Electrodiagnostic studies, EDX, electromyography, EMG, and nerve conduction studies, NCS, are absolutely key tests, especially when differentiating between nerve problems, neuropathies, muscle problems, myopathies, and issues at the neuromuscular junction, like myasthenia gravis. NCS measures how well electrical signals travel along nerves, while EMG records the electrical activity within muscles. Together, they help localize the source of the weakness. Is it the motor neuron itself, the nerve fiber, the neuromuscular junction, or the muscle? A key nuance with EDX is timing, particularly in acute situations. Changes related to nerve damage, like signs of denervation on EMG, can take up to a few weeks to fully develop. So very early testing, say within days of onset, might appear falsely normal or underestimate the severity. A repeat study later might be necessary.
And if myopathy is suspected but blood tests and EDX are inconclusive?
Then a muscle biopsy is often considered the definitive test for diagnosing specific types of myopathies, especially inflammatory ones like polymyositis or inclusion body myositis if there aren't clear skin findings for dermatomyositis. It's an invasive outpatient procedure, usually done under local anesthetic. Ideally, the biopsy is taken from a muscle that is clinically affected but not severely weak or atrophied, as end-stage muscle is often replaced by fibrosis and fat, making diagnosis difficult. Beyond these, there are more specialized tests. A lumbar puncture to analyze cerebrospinal fluid, CSF, might be needed if a central nervous system infection or inflammatory condition is suspected, but it's contraindicated if there's suspicion of raised intracranial pressure or a spinal block. Genetic testing can confirm hereditary neuropathies or myopathies. Specific antibody tests like anti-acetylcholine receptor antibodies for myasthenia gravis are crucial when indicated. We can also use functional strength tests observing the patient performing tasks like squatting, step-ups, which give real-world insight into the impact of weakness, complementing the formal MRC grading.
And interestingly, for diagnosing muscle pain, there's a protocol using electrical stimulation via a muscle pain detection device to help identify the muscular origin of regional pain, sometimes used instead of manual palpation.
So it's an iterative process: history, exam, targeted investigations, each step refining the diagnosis.
Precisely, that's the journey.
That systematic approach is clearly essential. So once a diagnosis is established, which, as we've heard, can be quite an involved journey, what does the pathway to recovery and management look like? What are the contemporary treatment strategies for arm weakness, ranging from conservative care right through to advanced interventions?
The treatment pathway is always fundamentally multimodal, and it has to be highly tailored to the specific underlying cause and, of course, the individual patient's needs, goals, and overall health. We typically start with conservative and self-care measures where appropriate, and their importance really shouldn't be underestimated, especially for musculoskeletal or overuse issues. Rest is often paramount, initially avoiding activities that clearly aggravate the pain or weakness, allows inflamed tissues or strained muscles time to heal. Temperature therapy can be very effective symptomatically. Applying heat helps improve blood flow and relax tight muscles, while applying ice helps decrease acute pain and swelling. Patients often find one works better than the other for them. Simple over-the-counter pain relievers, like ibuprofen or paracetamol, are often sufficient for managing mild to moderate symptoms, particularly pain associated with inflammation. Supportive devices like splints or braces can be very helpful. For example, a wrist splint for carpal tunnel syndrome helps keep the wrist in a neutral position, reducing pressure on the median nerve, especially at night. Slings can support a weak shoulder or arm.
And activity modification.
Crucial. Alongside rest, gentle exercises, massage, and stretching are often introduced early on, once acute symptoms allow. These aim to improve flexibility, maintain range of motion, improve circulation, and potentially reduce pressure on nerves. Working on increasing range of motion once muscles are warmed up is key. Lifestyle modifications are also vital. Good nutrition, ensuring adequate protein intake for muscle repair and strength is important. Maintaining adequate hydration, as dehydration can sometimes worsen muscle fatigue and cramps. Good posture is often overlooked. Avoiding hunching shoulders or prolonged wrist flexion can reduce strain on arm muscles and nerves. Taking frequent short breaks from repetitive motions, whether typing, using tools, or playing an instrument, is essential for preventing or managing RSIs. Varying exercise routines also helps reduce overuse injury risk. And effective stress management can help, as stress can certainly exacerbate muscle tension and pain perception. Finally, robust management of chronic underlying conditions is paramount. Working closely with the patient's GP or relevant specialist to optimize control of conditions like diabetes or thyroid disorders is critical to lowering the risk of associated nerve damage or weakness.
It sounds like empowering the patient with these self-management strategies is a really significant part of the initial approach. But when these aren't sufficient, what pharmacological interventions come into play?
Indeed. When conservative measures aren't enough, or for conditions requiring more specific treatment, we move to pharmacological interventions. For more severe pain, stronger prescription painkillers might be necessary, sometimes including neuropathic pain agents like gabapentin or amitriptyline if nerve pain is prominent. Anti-inflammatory drugs are a cornerstone for many conditions. Corticosteroids are powerful anti-inflammatories, available orally, intravenously for severe flare-ups, or via targeted injection into specific joints or around tendons to reduce local inflammation and pain. For underlying autoimmune conditions causing most weakness, such as polymyositis or myasthenia gravis, immunosuppressants are often required. These medications modulate the overactive immune system, targeting the root cause of the inflammation and weakness. Options range from methotrexate to azathioprine, mycophenolate, or biologic agents, depending on the specific condition and severity.
And what about therapies like physio?
Physical and occupational therapy are absolutely indispensable components of recovery for almost all causes of significant arm weakness, especially when function or range of motion is limited. Physical therapy focuses on targeted exercises designed to progressively improve strength, flexibility, coordination, balance, and overall endurance. A physiotherapist develops a tailored program to address the specific deficits identified, guiding the patient through recovery and helping prevent re-injury. It's often the bridge between diagnosis and returning to desired activities. Occupational therapy complements this by focusing on function in daily life. OTs provide practical strategies, adaptive equipment recommendations, and techniques to help patients perform daily activities, dressing, cooking, working despite their limitations. They help patients adapt and improve independence, significantly boosting quality of life. For our architect, Mr. Harrison, if weakness impacts his ability to draw or use CAD software, occupational therapy would be critical.
Right, focusing on practical, real-world function. You mentioned injections earlier, particularly corticosteroids. Are there other injection techniques used?
Yes. Beyond simple steroid injections, there are other techniques. For instance, muscle tendon injections, MTIs, represent a more comprehensive protocol, sometimes combining elements of prolotherapy, injecting irritant solutions to stimulate healing, with trigger point injections, aiming to treat the entire affected muscle tendon unit. Crucially, these MTIs are often followed by a structured post-injection rehabilitation program, typically involving neuromuscular electrical stimulation, NMES, to activate muscles, followed by a validated exercise program. One clinical trial looking at this combined approach for chronic pain showed quite significant improvements. Patients reported an average decrease of 62% in pain severity and 68% in pain interference scores 1 month after treatment, much greater than in untreated controls. This highlights the potential benefit of combining targeted injections with active rehabilitation. And as mentioned before, for painful neuromas resulting from nerve injury, specific injections or minor surgical procedures can often provide substantial relief from debilitating pain.
That combination of targeted intervention and structured rehab seems powerful. When do you escalate to considering surgery?
Surgical interventions become necessary in several scenarios. For severe acute injuries like complex fractures or complete ligament tendon tears causing instability and weakness, when conservative measures have definitively failed to resolve chronic symptoms like persistent nerve compression, or for structural problems that simply cannot be addressed non-operatively. For nerve compression, nerve release surgery is common, for example, carpal tunnel release or ulnar nerve decompression, where the surgeon cuts ligaments or removes tissues pressing on the nerve to relieve pressure and improve function. For severed or badly damaged nerves, various nerve repair techniques exist. Surgeons might directly suture nerve ends together, use a nerve graft, taking a piece of sensory nerve from elsewhere in the body to bridge a gap, or use synthetic conduits or donor nerve allografts. The aim is to allow nerve fibers to regenerate across the gap, restoring signal transmission. Targeted muscle reinnervation, TMR, is a more specialized technique used primarily for managing painful neuromas, especially in amputees, but also sometimes after other nerve injuries. It involves rerouting the cut nerve endings into nearby small motor nerves to give them something functional to connect to, reducing pain signals. Spinal surgery might be required for severe cervical radiculopathy or myelopathy due to disc herniation or stenosis that hasn't responded to conservative care. Procedures like discectomy, removing the herniated disc, laminectomy, removing part of the vertebra to create more space, or spinal fusion, joining vertebrae together for stability, aim to decompress the affected nerves or spinal cord.
And recovery after surgery.
It's really important to set realistic expectations. Recovery time varies hugely depending on the condition and the specific surgery performed. Nerve recovery, in particular, can be slow. Nerves regenerate at roughly 1 millimeter a day or an inch a month, so it can take many weeks, months, or even years to see the full extent of improvement after nerve repair, though most patients do experience significant improvement compared to their preoperative state. Rehabilitation after surgery is just as crucial as the surgery itself. And finally, a word on prevention. Beyond treating existing weakness, preventing it in the first place is key. This involves taking breaks from repetitive tasks, using ergonomic setups, warming up properly before exercise or strenuous activity, varying exercise routines, maintaining good posture, and actively managing chronic health conditions like diabetes and thyroid disease. Using safety equipment, helmets, seatbelts prevents traumatic injuries, and seeking prompt treatment for infections can prevent neurological complications.
That's a really clear overview of the entire management pathway. Now let's pivot to something incredibly important for all our listeners, whether in primary care or specialist settings. Discerning when arm weakness is just a minor issue versus a genuine medical emergency. What are the absolute must-not-miss signs that demand immediate professional help? And what are the potential consequences of delay?
This is, without doubt, one of the most critical takeaways. Delaying assessment and treatment for serious causes of arm weakness can, unfortunately, lead to permanent functional loss, chronic pain, significant disability, or even worse outcomes in conditions like stroke or rapidly progressive neurological disorders. Recognizing the red flags is paramount. First and foremost, sudden onset of arm weakness, especially if there's no obvious preceding injury or cause, is always highly concerning.
That's the AFAS.
Exactly. It should always prompt immediate medical attention, usually via emergency services, as it's a cardinal sign of stroke. Time is absolutely critical in stroke management. Time is brain. Beyond sudden onset, look very carefully for accompanying neurological symptoms. If the arm weakness is associated with numbness or tingling that spreads rapidly up the limb or to other parts of the body, if it's accompanied by incomprehensible or slurred speech, dysarthria, facial drooping, confusion, disorientation, or any decreased level of consciousness or alertness, like fainting or becoming unresponsive. These are all urgent signs. A severe headache, particularly if described as sudden onset or the worst headache of their life, warrants immediate investigation for potential subarachnoid hemorrhage or other vascular events. Any sudden changes in or loss of vision is also a major red flag. Complete paralysis, the total inability to move the arm or another body part, is clearly an emergency requiring immediate assessment.
What about the functional impact or progression?
Yes, even if the onset isn't sudden, if the weakness significantly interferes with daily activities, making it impossible to work, care for oneself, or if it disrupts sleep, it needs prompt evaluation. Similarly, if the weakness fails to improve with appropriate self-care or conservative measures over a reasonable time frame, or, crucially, if it is progressively worsening, then further investigation is essential. Don't just wait and see indefinitely if things aren't getting better or are actively deteriorating. And finally, a critical red flag is any sign of respiratory distress or difficulty breathing, however mild it might seem initially. If the weakness is affecting respiratory muscles, this can rapidly escalate into a life-threatening situation needing urgent intervention.
So the core message is,
The core message is that sudden, unexplained one-sided muscle weakness, hemiparesis, or weakness associated with any of those major neurological or systemic red flags should always be treated as a medical emergency until proven otherwise. When in doubt, especially with acute neurological symptoms, err firmly on the side of caution and advise immediate medical attention via emergency services. The potential cost of delay is just too high.
what a truly comprehensive deep dive into arm weakness. It's become abundantly clear that this symptom, while seemingly straightforward, really does open up a vast and intricate world of diagnostic pathways and treatment considerations for us as medical professionals. This has been incredibly insightful. If you were to leave our listeners with one final thought, perhaps something provocative for them to mull over after this discussion, what would it be?
My final thought would be this. Try not to perceive arm weakness as merely an isolated symptom affecting a limb. Instead, really view it as a crucial clinical signal, a messenger from the body, that almost invariably requires a broad, integrated, often interdisciplinary perspective to diagnose accurately and, most importantly, to achieve the best possible outcomes for your patient. The real effectiveness of any management plan we devise hinges entirely on that initial prompt, detailed evaluation, looking across the neurological, the muscular, the systemic domains. Because only by doing that thoroughly can we genuinely unearth the true root cause and devise a treatment strategy that not only addresses the weakness but truly improves that individual's function and quality of life. It's about seeing the whole patient, understanding the context, not just focusing narrowly on the weak arm itself.
It's a powerful reminder to maintain that holistic perspective. Thank you so much for sharing your invaluable expertise and insights with us today on Deep Dive Ortho. We sincerely hope that you, our listener, found this exploration as enlightening and clinically relevant as we did. If you've gained new perspectives today, please do consider rating and sharing this deep dive with your colleagues. It genuinely helps us reach more medical professionals like you.